Right now, there is a pill sitting in millions of medicine cabinets across this country that doctors have been prescribing for decades to help with sleep, with anxiety, with low mood. Millions of seniors take it every single night, trusting it completely. But a major study published in January 2026 in one of the most respected medical journals in the world found that this class of antidepressant is doing something to the aging brain that nobody warned you about. If you are over 60 and you take any antidepressant, I need you to stay right here, because what I am about to share could explain symptoms you have been blaming on getting older. There are 5 specific antidepressants linked to accelerating cognitive decline in older adults, and the most commonly prescribed one is probably not the one you expect. I'm Dr. Richard James. I have over 3 decades of clinical experience in senior health, and I need to explain something that is not getting nearly enough attention in the medical community right now. Antidepressants are among the most commonly prescribed medications for adults over 60. Millions of seniors take them daily. For many, they are genuinely helpful and even life-saving. But there is a specific class of antidepressant that works differently inside your brain after 60, and the damage it causes does not show up overnight. It builds, quietly, over months and years. We are not talking about mild side effects. We are talking about measurable, accelerating cognitive impairment in people who were told this medication was helping them. And for roughly 2.6% of older adults on these drugs, that translates to hundreds of thousands of people whose brains are under chemical assault right now. The question is not whether these drugs have side effects. The question is why, in 2026, they are still landing in your medicine cabinet. That answer will frustrate you. Here is what changes inside your brain after 60 that makes this entire conversation critical. Your brain runs on a chemical called acetylcholine. Think of it as the fuel your brain needs for memory, for focus, for the ability to recall a name or follow a conversation. After 60, your brain produces less of it, significantly less. Now, anticholinergic drugs do exactly what the name suggests. They block acetylcholine. In a 30-year-old brain, that is a mild inconvenience. The system has enough reserves to compensate. In a 65-year-old brain, it is like cutting the power to a building that was already running on a backup generator. And here is the part most doctors never sit down and explain. This effect is cumulative. Every day you take one of these medications, the anticholinergic load on your brain increases. It does not reset, it stacks. And the longer you take it, the harder it becomes for your brain to recover what it has lost. Once you understand this mechanism, the 5 drugs I am about to name will make complete sense. And the first one is a drug that millions of seniors have been prescribed for decades. But first, the study that brought all of this into sharp focus. In January 2026, a team led by Dr. John Maffei at UCLA published a study in JAMA that examined prescribing patterns for potentially inappropriate brain-affecting medications in older adults. They analyzed Medicare claims data from 4,842 adults aged 65 and older, tracked between 2013 and 2021. And what they found should concern every senior taking an antidepressant. Approximately 2.6% of seniors in their sample were still being prescribed antidepressants with strong anticholinergic properties. That percentage may sound small, but do the math. Applied to the Medicare population, that is hundreds of thousands of people whose brains are being exposed to a drug that actively suppresses the one neurotransmitter they need most for memory and cognition. And here is what makes this worse. More than 2 out of 3 of those prescriptions had no documented clinical justification. That means the majority of seniors receiving these drugs had no clear medical reason on file for why they were taking them. This is not a wellness blog opinion. This is peer-reviewed research from JAMA, one of the most respected medical journals in the world. That is what the research says. But the real question, the one that should bother every single one of you, is why these drugs are still being handed out like they are harmless. You might be wondering why, if the evidence is this clear, your doctor is still prescribing these drugs. And the answer is something that frustrates me deeply. It comes down to 3 things. First, prescribing inertia. These are old drugs. Doctors learned about them in medical school. They are cheap, they are familiar, and when something has been prescribed for 40 years, it takes an enormous amount of momentum to change the pattern. Second, Cognitive side effects in seniors are almost always attributed to normal aging. Your family notices you are losing words, you miss appointments, you forget a conversation from yesterday, and everyone, including your doctor, says it is just what happens when you get older. Except sometimes it is not aging at all. It is your medication. I had a patient, a 71-year-old retired school teacher, Margaret, sharp her entire life, crossword puzzles every morning. Over the course of 2 years, her family noticed she was forgetting conversations, losing words mid-sentence, missing appointments she had kept for decades. Her doctor ran tests and told her it was early cognitive decline, age-related, nothing to do. Except it was not age. It was her antidepressant, a tricyclic she had been on for 8 years. When we identified the anticholinergic burden and tapered her off under medical supervision, her cognition improved within months. Her daughter called me crying. And the third reason? There is no built-in system in most primary care practices to screen for anticholinergic burden. It is not a box that gets checked. It is not flagged in most electronic health records. It is a gap in the system, not a failure of your individual doctor. So now you understand why this happens. But you still do not know which specific drugs are doing this. That is exactly what I am about to tell you, and I have ranked them so you know which one to pay attention to first. Number 1. Imipramine, brand name Tofranil. This is one of the oldest tricyclic antidepressants still in circulation. It was originally developed for major depression, but over the years it has been prescribed for everything from nerve pain to chronic anxiety. Imipramine carries an anticholinergic burden score of 3 on the ACB scale, the highest possible rating. That means every single day a senior takes this drug, it is actively blocking acetylcholine at a clinically significant level. A 2019 study published in JAMA Internal Medicine, involving nearly 59,000 dementia patients and over 225,000 controls, found that anticholinergic antidepressants like imipramine were among the drug classes most strongly associated with increased dementia risk. Number 2. Amitriptyline. You may know it by the old brand name Elavil. This is one of the most widely prescribed tricyclic antidepressants in history. Today, it is commonly given to seniors for nerve pain, migraines, and insomnia, often at doses doctors consider low. But here is what the research shows. Amitriptyline has one of the highest anticholinergic loads of any drug in its class. It scores a 3 on the ACB scale, just like imipramine. And the cognitive effects do not care about your dose. Even at the low doses typically prescribed for nerve pain, amitriptyline is still blocking acetylcholine in your brain every single day. The 2023 Beers criteria, which is the gold standard guideline for medications to avoid in older adults, specifically lists amitriptyline as highly anticholinergic and recommends against its use in seniors. Yet it is still being prescribed every single day. Think about that for a second. The most respected prescribing guideline in geriatric medicine says, do not give this drug to older adults. And it is still showing up in prescriptions across the country. Those first 2 are concerning enough. But the next one on this list is a drug that most people would never suspect. Number 3. Nortriptyline, brand name Pamelor. This one surprises people because nortriptyline is often considered the safer tricyclic. And compared to amitriptyline, it does have a somewhat lower anticholinergic profile. But lower does not mean low. Nortriptyline still carries a clinically significant anticholinergic burden, especially in seniors whose acetylcholine reserves are already depleted. It is frequently prescribed for chronic pain and depression in older adults, precisely because doctors believe it is the gentler option. And that belief is the problem. Because when a doctor considers something gentle, they are less likely to question whether it belongs in your regimen at all. The University of Washington study led by Dr. Shelley Gray found that tricyclic antidepressants as a class, including nortriptyline, were among the most common anticholinergic drugs contributing to elevated dementia risk over a 7-year follow-up period. If you are on nortriptyline and your doctor told you it was the safer choice, they were comparing it to worse options. That does not make it safe. Now this next one is the one I see in my practice constantly, and it is one of the most overlooked problems in senior prescribing today. Number 4. Paroxetine, brand name Paxil. This is the one that catches people off guard. Paroxetine is not a tricyclic. It is an SSRI, a selective serotonin reuptake inhibitor. Most people assume SSRIs are free from anticholinergic effects. And for most SSRIs, that is true. But paroxetine is the exception. It is the only SSRI with significant anticholinergic activity, and it is prescribed to millions of older adults for anxiety, depression, and hot flashes. A large nested case control study published in JAMA Internal Medicine in 2019, involving over 284,000 participants, found that anticholinergic antidepressants, including paroxetine, were significantly associated with increased dementia risk, even when exposure occurred up to 20 years before diagnosis. If you are taking an SSRI and you assumed you were in the clear, check the name on your bottle. And this brings us to the most important one on this entire list. If you remember nothing else from this video, remember this drug name. Number 5. Doxepin. Brand names Sinequan and Silenor. This is the one the research keeps circling back to. Doxepin is the single most commonly prescribed anticholinergic antidepressant in older adults, according to the University of Washington study. And here is why that matters. Doxepin is frequently prescribed at low doses for insomnia. Doctors hand it out as a sleep aid. Many seniors do not even realize it is an antidepressant. They think of it as their sleep pill. But even at low doses, doxepin's anticholinergic burden on the aging brain is significant. The Gray et al. Study found that taking as little as 10 milligrams per day of doxepin for more than 3 years was associated with a measurably higher risk of developing dementia. That is a dose many seniors take every single night without a second thought. And because it is marketed for sleep, it flies under the radar. Nobody questions their sleep pill. Nobody asks whether the medication they take to rest is quietly eroding the brain function they need to live independently. That is what makes doxepin the most dangerous drug on this list. Not because it is the strongest anticholinergic, but because it is the most invisible. Now I know some of you are thinking, but my doctor put me on this. He would not prescribe something that hurts my brain. And I understand that completely. But here is what the research consistently shows. Anticholinergic burden is not something most primary care doctors are actively screening for. It is not a failure of your doctor. It is a failure of the system. And let me be absolutely clear about something. Do not stop taking any medication based on this video. That is not what I am asking you to do. What I am asking you to do is far more powerful than that. If you have been on one of these drugs for years and you feel fine, that does not mean the effect is not there. This kind of cognitive change is gradual. You adapt to it. The people around you notice before you do. The JAMA data shows measurable impairment even in patients who report feeling well. I am not telling you to stop your medication. I am telling you to have a specific conversation with your doctor. There is a difference, and that difference matters. So here is exactly what I want you to do. This is the protocol I give my patients, and I want you to follow it precisely. Step 1. Tonight, before you go to bed, I want you to write down every single medication you are currently taking. Prescription and over-the-counter. Include the sleep aids. Include the supplements. The full list. Step 2. This week, take that list and look up each medication on the Anticholinergic Cognitive Burden Scale. You can find a free calculator at acbcalc.com, or simply ask your pharmacist to review your list for anticholinergic burden. Any drug with a score of 2 or 3 deserves a closer look. Step 3. At your next doctor's appointment, bring that list and say these exact words. Can we review my medications for anticholinergic burden? That one sentence could change the trajectory of your cognitive health. Step 4. If your doctor identifies a high-burden drug, ask about alternatives with lower anticholinergic activity. For tricyclic antidepressants, SSRIs like citalopram or sertraline are often effective substitutes with minimal anticholinergic effects. But any switch must be gradual and supervised. Never taper an antidepressant on your own. Step 5. Track. Over the following weeks, pay attention to specific cognitive markers. Word recall, name retrieval, how easily you follow a conversation. These are the earliest signals that something is shifting. You now know what most people in your position do not. You know which drugs carry the highest risk. You know the mechanism. You know why the system has failed to catch this. and you have a specific plan to act on it. That is not a small thing. That is the difference between someone who watches their memory slip away, wondering why, and someone who walks into their doctor's office armed with the right question at the right time. Your brain has been trying to keep up despite everything working against it. The fatigue, the fog, the moments where a word is right there but you cannot reach it. For some of you, those were not just aging, they were signals, and now you know what they mean. If someone you care about is over 60 and takes an antidepressant, send them this video today. You might never know it, but you could be the reason someone you love protects their memory before it is too late. I'm Dr. Richard James. If this helped you understand something nobody had explained before, subscribe, because next week I am covering the other drug classes beyond antidepressants that carry hidden anticholinergic risk. There are more of them than you think, and some of them are sitting in your medicine cabinet right now. Take care of yourself tonight. I'll see you in the next one.